in. So good morning, good afternoon, and good evening, depending on where you're joining from. My name is Renuka Bery, and I'm a social and behavior change specialist with USAID Advancing Nutrition. And just one more plug, if you haven't introduced yourself already in the chat, please go ahead and do so. On behalf of University of North Carolina at Chapel Hill and USAID Advancing Nutrition, we would like to thank you for joining us today for the Family Inclusion and Nutrition Through Engagement Community of Practice, or the FINE COP for short. Today, we will be focusing on engaging grandmothers and fathers in nutrition and WASH activities. Before we begin, I just want to remind everyone that we have our previous recordings on our webpage, and I've just sent that into the chat. And that is for you to refer back to. And after the conclusion of this meeting, we will also put that up on there. So please do take a look at that. So we'll start off today with a presentation on learnings from USAID Projet Nutrition et Hygiène on engaging fathers and grandmothers in nutrition and WASH activities in Mali. And then we'll have time for some questions on the presentation before we move into some small groups. And to conclude, we'll have some wrap up and then some Zoom poll questions that you can answer before you all leave today. So I'll now introduce our presenter today. So Renuka Bery is a global public health professional and an inspirational team leader who manages for excellence. As a strategic and collaborative problem solver, she leverages project management, budgeting, supervision, and training competencies to design, implement, and measure effective USAID and donor-funded programs that get results. She has a deep understanding of and hands-on experience in behavior change and community development in diverse global settings that drives her passion for addressing challenges that can improve people's lives. Her recent technical health areas focus on maternal and child health, nutrition, family planning and reproductive health, WASH, and infectious and neglected tropical diseases. Ms. Bery works for Save the Children, where she currently oversees the breakthrough action activities in Niger. She also provides technical SBC support to the program cycle support activity under the IDEAL project. She has worked in Africa and Asia and speaks French. Thank you so much, Renuka, for joining us today. We're also lucky to have Diana join us today. Diana Allotey, PhD, is a public health nutritionist with over 8 years of experience with Bill and Melinda Gates funded and USAID funded global health research and programs. In her role as a monitoring and evaluation lead, she provides technical support to advance the quality, effectiveness, and efficiency of Vitamin Angel's program division, monitoring and evaluation strategy. Diana just completed her doctoral studies in nutrition at the University of North Carolina at Chapel Hill. Her research focused on examining the factors which influence the success of infant and young child feeding, social and behavior change communication programs in Nigeria. She also has an MPH in nutrition from the same institution. So now, without further ado, we'll have Renuka present. Over to you, Renuka.
Great, thank you so much. I'm really happy to be here and to talk about one of my favorite projects. We'll wait for it to come up. So today we're going to talk about involving family members in improving nutrition and what we did under the PNH project to do that. Next slide. So PNH managed a full package of activities in about 236 villages that served over 200,000 people. And we strengthened the health resource centers in an additional 4 districts in the Sikasso region of Mali. The project was focused on helping pregnant women to improve their nutritional status, as well as that of children under 5, but we were particularly focused in children under age 2. And the full package of activities included nutrition activities, WASH activities, and agriculture activities. Next slide. So this diagram, I know it's hard to read, but it kind of gives you a sense of what our program strategy was. It was an integrated program. And while we focused on mothers and primary caregivers, we had a number of activities that involved men and other caregivers such as grandmothers or mothers-in-law. For example, we had care groups with new mothers that were led by what we called mama leaders. Usually they were older women, but maybe not necessarily grandmothers yet. But we also sought ways to involve the grandmothers and the fathers in these activities. Sometimes we had sort of husband groups or grandmother groups to reinforce information that was being shared with the mothers. Sometimes we shared information through the farmer field schools. Again, they were focused on women, but men were engaged and involved. Wash activities were particularly of interest to men because the changes that were seen were very, very visible. They would say there's no more, the village is clean. There's no more feces in our village. And when we focused on hygiene, there was a lot of engagement with youth groups, so boys and girls, as well as the larger community members who committed to ensuring the community was swept and the animals were penned and things like that. Next slide. So the community engagement activities we had focused on village coordinating committees. Usually these committees existed, but maybe they were moribund or not that functional, or maybe they were, but we saw that as an important area to involve men because they form the bulk of the membership. But as we worked with mothers, they became more confident and vocal in expressing ways that their families could help. Nutrition groups were focused on these mothers, but as I mentioned, sometimes there were what we call husband schools or the grandmother groups. Women farmers included young and older women who received the same messages. There might be about antenatal care or there was a lot of focus on dietary diversity with the agriculture groups. And then we worked with the health centers in the area to strengthen them and to build kind of a bridge between the community and the health center. So there was greater trust, and that community members would feel confident visiting the health centers. Next slide. So key component of these activities was sharing the same information over and over again within all of the different groups. The importance of antenatal care, exclusive breastfeeding, a varied diet, feeding sick children. They were emphasized in home visits. They were emphasized in group meetings and other community events. And one thing we found, and we really tried to change, was that the men controlled sort of the crops and what got sold and what got kept. So we tried to have men commit to keeping a certain percentage of the harvest for the family. So 10 to 15%, so that they had food throughout the year, all the way up until the end of the, before the new harvest, when they would call that the hungry time. And that was a really new concept in these households, but many, many households committed to doing that. Next slide. I mentioned the village coordinating committees were dominated by men, but we tried to make sure that women were involved and had vocal roles. When we were doing community-led total sanitation activities, communities decided to engage the whole community, especially youth groups. So the boys and the young girls sometimes would just go out and make sure that the village was cleaned up, and these activities, like I mentioned, were very noticeable. And then they also noticed that after a lot of these activities were in place and sort of happening more regularly, there was more breastfeeding, there was more attendance at antenatal cares, men started saying, well, we're not spending as much money on the health centers and taking our sick kids to the health centers. And so they saw actual benefits. Next slide. Just a few of the end of project results. I mean, we had some really great results. We had a reduction in underweight. We had a reduction in stunting. Exclusive breastfeeding went up a lot. Dietary diversity also increased. The hygiene and latrine activities. We had 200 communities that were open defecation free. So by the end of 6 years, we really had accomplished quite a bit. Next slide. So I think, as everybody on this call knows, changing behavior is really difficult. So it's kind of interesting to explore what might have motivated people to change. I think first and foremost, everybody in the community wants to have a healthy family. But again, it's difficult to go against traditional ways of doing things. Grandmothers or mothers-in-law have a strong voice in the community, and women don't often have agency or feel empowered to try something new or do something that goes against the social norm. Even in my experience, my mother-in-law said after 3 months, "How long are you going to breastfeed your child?" So, they had to sort of gain agency. Also, in Mali, as in many, many other countries, men make a lot of the financial decisions, and women don't have the buying power or the couple communication often to intervene in these decisions. And I think the care group activities, while on the one hand, they were there to sort of share information and make sure that women are repeatedly getting the same information about nutrition and good practices. It also helped them to gain confidence and to sort of find allies within the community, whether it was the mama leader who was in charge of their group or other their mother-in-law, who also were learning about these improved practices and sort of getting them on their side to sort of share what they wanted to do differently. And I think that was very very useful. And men were more convinced when they saw that there were benefits. So again, like, they weren't spending money on health activities. They were seeing that their communities were clean. And the ODF communities, the open defecation free communities, found that they were visiting the health center much less frequently. Next slide. So I also wanted to share some more recent observations from the Al Barka project, which is also in Mali. It's in the northern part of Mali, so where the PNH project was more in the breadbasket in the southern part of Mali. So in the Al Barka project, it's less arable, there's greater insecurity, but they did a lot of focus groups to try to find out what were some of the barriers to breastfeeding, or improving nutrition. And one of the key things women said were that they were stressed or they didn't have time to breastfeed. So as a community, they came together to say, what can we do? What can we do to help this? And I think it was the men and the mothers-in-law who said, well, we can help take care of the household chores during the, when moms are exclusively breastfeeding, and maybe that will ease their burden. We can collect firewood, we can clean the latrines or make sure that there are latrines and water. We can collect water so that women don't have to walk long distances. And I think they also found out that men didn't understand the importance of dietary diversity. And so they really tried to focus on some of those activities in the husband schools. So when men met, they didn't only talk about ways to improve their situations, but to improve their families. Next slide. So I guess what are the key approaches to consider or to build upon? And these are some of the ones that I've pointed out, but there's definitely many others that we can work on, or we can identify to improve these situations. So finding champions who are trusted in the community is a key activity to promote new behaviors. And while community groups may focus on passing along information, they're also about building trust and confidence and empowering women to speak up. And sometimes it's necessary to explore the underlying barriers to practicing these behaviors, as the Albarca example showed. We found that when women had agency and purchasing power, they almost always used it to benefit their children. Finding ways to empower youth is really another key activity. And if you catch them young, they're more likely to remember or do things differently as they grow up and become fathers and mothers-in-law themselves. Next slide. So thank you. This is a picture of two grandmothers who were working together with the mom to make sure that their grandson was a healthy baby. And this is a father who was supportive of exclusive breastfeeding and had a very healthy son after having his earlier child be at the health center very often. So he said he was convinced. And I just wanted to share with you, we have something on the Development Experience Clearinghouse called Stories from the Heart, if you want to see other stories that are about all of the activities that we did in PNH, but there are quite a number of stories about involving families in nutrition. So thank you.